Good morning, everyone. Patients with benign intestinal lesions, such as deep endometriosis or diverticulosis, often get or go through conventional laparoscopic bowel resection. Unfortunately, 10 to 55% of them develop either anastomotic leakage or infectious complications, indicating the unmet need of a new type of surgical intervention. Our systematic review and meta-analysis found that in one disease, namely deep endometriosis, the natural orifice specimen extraction technique can decrease these complications by 61 to 75%. Therefore, clinicians should use this new surgical intervention whenever it is possible, and of course, guidelines should be renewed of our results. My name is Botond Bényi. I will start work as a resident physician at Semmelweis University Department of Obstetrics and Gynecology from September. My supervisors are Nándor Ács and Attila Bokor. My SMS is Lőrinc Fribalski. My vision is an improved quality of life in patients who suffer from benign intra-abdominal lesions, and my mission is to find the most effective surgical technique for the treatment of benign intra-abdominal lesions. We have two ongoing projects. In the first one, we investigate the safety and efficacy of natural orifice specimen extraction in the treatment of benign intestinal lesions. However, in the second one, we investigate the same technique, but in the treatment of benign uterine and adnexal lesions. So let's start with the first one, which is titled as Investigating the Safety and Efficacy of Natural Orifice Specimen Extraction in the Treatment of Benign Intestinal Lesions. Globally, around 240 to 300,000 of bowel resections are performed a year due to benign diseases like deep endometriosis, diverticulosis, diverticulitis, volvulus, or IBD. The resected segment can be removed through an artificial orifice, like a Pfannenstiel incision, or a natural orifice, like the anus or the vagina. But the incision used for the specimen removal results the loss of advantages of minimal invasive techniques and an increased risk of hernia, fistula, wound infection, postoperative pain, and psychological distress. However, the nose technique has emerged as a rising star in the field of minimal invasive surgery, so we hope that it can be the way forward to reduce these complications and to improve the surgical results. At the end of the day, we would like to know if nose provides better clinical results and fewer surgical complications compared to conventional methods. Our population is patients with benign intestinal lesions. We compare the nose technique to conventional methods, and our outcomes are the surgical and functional outcomes and complications. With this search key, we earned a little bit more than 12,000 of hits. And after the flowchart selection, we got 42 eligible full texts. So let's continue with my results. This forest plot examines the incidence of anastomotic leakage after the use of nose technique or conventional laparoscopic bowel resection among patients with deep endometriosis. Since the anastomotic leakage is the most serious complication after performing bowel anastomosis, it is essential to use a technique that minimizes this risk. The scale ranged between 0 and 1, where 0 indicates the optional outcome when no anastomotic leakage is occurred. However, the 1 or the 100% means that all patients develop anastomotic leakage. Our aim is to determine which surgical technique is associated with a lower risk of anastomotic leakage. Our pooled patient cohort contains a little bit more than 800 of patients, mostly from prospective and retrospective cohort studies, as well as one randomized control trial. The heterogeneity was low in both groups. However, the confidence intervals were moderate, which can be attributed to the low number of cases, the various localizations of endometriotic nodules, and the various experience level of the surgical teams. the pooled anastomotic leakage rate was 2% in the conventional group and 0.5% in the nose group. This means that with the use of nose technique, there is a lower incidence of anastomotic leakage compared to conventional methods, and the analysis revealed a clinically and statistically significant difference between the two techniques. So these results support the potential benefit of natural orifice specimen extraction over the conventional laparoscopic bowel resection in anastomotic leakage formation among patients with deep endometriosis. The second forest plot examines the incidence rate of infectious complications among patients with deep endometriosis and other benign diseases as well after the use of nose technique or the conventional laparoscopic bowel resection. Since infectious complications slow down healing, increase pain, or lead to fistulas or wound dehiscence, it is essential to avoid these complications. The scale used in this diagram ranges between 0.01 to 100, where the value of 1 means that there is no difference in infectious complication rate between the two interventions, and the values to the left of 1 means a lower, while the values to the right of 1 means a higher infectious complication rate with nose technique. Our aim is the same: to determine which surgical technique is associated with a lower risk of infectious complication. The analyzed patient cohort contained almost 700 patients, mostly from prospective and retrospective studies. The heterogeneity was low in both groups. However, the confidence intervals were moderate, which can be attributed to the low number of cases and the various disease types. The pooled odds ratio was 0.39 among patients with deep endometriosis and 0.93 among patients with other benign disease. This means that the use of nose technique decreased the infectious complication rate by 61% among patients with deep endometriosis and 7% among patients with other benign disease. The analysis revealed a clinically and statistically significant difference between the two techniques among patients with deep endometriosis. So our results support that the nose is associated with a lower risk of infectious complication compared to conventional methods among patients with deep endometriosis, and among other benign disease, the nose technique show results as good as the conventional laparoscopic bowel resection. And our next task is the manuscript writing. Let's continue with my second project, which is titled as Investigating the Safety and Efficacy of Natural Orifice Specimen Extraction in the Treatment of Benign Uterine and Adnexal Lesions. In the US, around 600,000 of uterine and 500,000 of adnexal surgeries are performed a year due to benign conditions like uterine fibroids, adenomyosis, endometrioma, or other benign cysts. The resected segment can be removed through an artificial orifice, like a financial incision, or a natural orifice, like the vagina. The incision used for the specimen removal results a lot of complications, and we hope that with the use of natural orifice, these complications can be reduced and better surgical results can be earned. At the end of our research, we would like to know if nose provides better clinical results and fewer surgical complications compared to conventional methods. Our population is patients with benign uterine and adnexal lesions. We compare the nose technique to conventional methods, and our outcomes are the surgical and functional outcomes and complications. With our preliminary research, we earned almost 8,000 of hits. We would like to submit the first project until November this year, and the second one until the March of 2026. And I would like to say thanks for your kind attention with a quote from Arthur Ashe. So start where you are, use what you have, and do what you can. Thank you very much.
Thanks for your presentation. I would like to ask if in your first project, it's up to the patient or the clinician to decide which technique to use.
Yes, thank you very much. So the technique is decided or chosen up to the clinical or the situation. So when the please concentrate on the endometriosis. So in those occasions when the endometriotic nodules take place in the lower place of the intestine. So for example, in the colorectal region, it can be done with the nose technique because it's easy to pull through the anus. But for example, and we can do the nose technique, but in those occasions when the endometriotic nodules take place on the small intestine or in upper part of the bowel, it's not so easy to do this procedure, and that's why in these situations the conventional method is used.
Thank you.
Thank you.
I think all of us feel that there is a renaissance of any kind of natural orificium surgery right now. Just an example, the latest American guideline about hysterectomy, which is mainly about robotic surgery, ended with the sentence that always consider vaginal root. So your topic is very great and up to date. I'm basically a gynecologist, so I'm more familiar with the V-nodes technique than the nose technique, which really requires nice laparoscopic skills, and I feel the learning curve of the V-nodes is pretty longer than usual in laparoscopic surgery. What is about your meaning in this case about the learning curve?
Yes, I am pretty sure that there is a bigger or harder and longer learning curve of these techniques. We in the early months, we compared the V-nodes and other nodes techniques to these nose techniques too, but we found that there are differences between the conventional nose technique and the natural orifice transluminal extraction techniques, so the nose techniques. So that's why we excluded these surgeries, but of course these nose and nose techniques has a longer and bigger learning curve, but after it with the earn of less bowel motility, less tissue damages, we can earn better results.
Yeah, surely you should exclude it to clarify the scientific question. Thank you.
Yes, it's very important because I'm a surgeon, and he said it has not many anastomotic leakage. And what was the treatment in these cases? It has many options, for example, for surgeons.
Yes, of course. So thank you for your question. These complications are classified according to the Clavian-Dindo classification, which means what type of cure is needed to heal these complications. So from medicine to surgery.
Reoperation, for example?
Yes. But it's mostly in cases of
rare resection, for example, or drainage, or
of course,
or ileostoma, or
most of them. In cases of anastomotic leakage, in most of time, reoperation is needed. But for example, in the infectious complications, there can be easier conditions, for example, in Clavian-Dindo 1 and 2 classes, when there is no reoperation needed.
Thank you so much.
Thank you.